Good morning, everyone. This is the second part of the lecture which we have done last week about fluids and electrolytes. And as in the previous lecture, I gave you a short introduction of body fluids compartments as well as the main electrolytes of the different body fluids compartments. Of course, we just have two lectures on this topic, and it's very hard to basically cover the acid base balance as well. And why we are studying this thing, what is the importance of this thing, I told you in the last lecture, but again, because in all the patients, especially surgical patients, in emergencies or before surgeries or after surgeries, or anyone who is hospitalized, of course, sometimes we put the patient on nothing per oral, so when the patient cannot take anything by mouth, so uh, we have to give them IV fluids. And what kind of IV fluids? Of course, there are many kinds are available. In this lecture, we are going to discuss them. We will try to cover the main points. And as I told you in the previous lecture, it's better to study acid-base balance in detail from physiology. A lot of things will be revised. And one more continuation of for this lecture, basically the next lecture which we are going to talk about, like the next week I'm talking, uh, the next week after this fluids and electrolytes will be finished, so our next lecture will be about shock. Okay, so uh, shock, now whenever anyone is in shock, and again in physiology we have covered what is shock. There are different type of shocks like hypovolemic or cardiogenic, or all these shocks, of course. um, Whenever a patient comes in shock, what we do resuscitation, and for resuscitation, of course, we give them some sort of volume expanders, or of course, like the blood which they lose, or the fluids which they lose from the body, we must replace them. And nowadays, of course, like the techniques of resuscitations have improved a lot, and more patients are surviving the shocks. Why? Uh, because of the availability of this good, like all this IV fluids and better techniques which are available nowadays. So that is about the next lecture. So what we will be starting with, of course, like in this lecture, we are going to discuss about the different type of fluids which are present, which are available, and which we can use in surgical patients. So let's start with the what kind of fluids are there. Um, okay, so fluid therapy, as I was talking about, that the importance of fluid therapy. And if you can see over here, see, uh, many points are written over here, like it is life saving in certain conditions, and when there is loss of body water, like with whatever it, either it's acute or chronic, so it can cause range of problems. Now these problems, of course, you would understand in more detail when you would know what are different electrolytes abnormalities can cause. For example, hyponatremia or hypernatremia, or for example, hypokalemia or hyperkalemia, right? So let's talk about the different types of fluids which are available. You can see over here uh, the fluids which are available. Uh, what you can say nowadays in clinical practice, right, is basically colloids, crystalloids, and blood products. Okay, so um, and depending on like okay for just for example, okay, I will talk about this thing a little like after introducing these things. See the colloids. Remember this thing that the colloids contain large molecules, right? So when they contain large molecules, basically they don't pass through the cell membrane. Okay, so of course, like the cell membrane is a semi-permeable membrane, as we know. So when we give and we are dealing with the same thing like in the last lecture I told you, like there is ICF or intracellular fluid, and there is ECF or extracellular fluid, and ECF is further divided into you can say uh, uh, the ECF one is the one in which like there is plasma, and then there is intracellular fluid where like the fluid in which different cells are suspended. So basically uh, uh, the plasma, or you can say the blood which is circulating in our body, so all the vital organs, for example our brain, our heart, our kidneys, they are getting perfusion by blood. And for example, uh, if someone had a trauma or a road traffic accident or anything, a stab wound, and um, one of his vessel is have a cut, so what will happen? Of course they will start losing fluid and or blood simply. So when they start losing blood, so there will be less amount or volume of blood in the intravascular space, and of course when the amount of blood in the intravascular space will be less, so what will happen that um, uh, the blood pressure will go down and the pulse rate will be increased, and the perfusion uh, to different parts of the body will be reduced. Especially what we are concerned with is the perfusion to the heart, to the brain, to the kidneys. So now, uh, for example, if we will give colloids, or which contain the large molecules, so what will happen? That they will stay in the intravascular compartment, and they will expand the intravascular volume. Okay, so now uh, I remember this thing. Whenever someone is losing blood, it's best to provide them with blood. But as we know that everyone have a different type of blood group A, blood group B, O, or AB, and also A positive or A negative or B positive, whatever. Of course, like it's not like just we can give same type of blood to anyone. Of course, in emergencies, when someone reached the emergency, they send a call to the blood bank to arrange blood or to give blood, send blood. And of course we have to cross match before giving. In like too much emergencies, of course, like they have some ready blood O negative which they can infuse to anyone, because like that is the one which is basically universal donors, so they can use that one. But uh, it takes time, to take the blood and start infusing with blood. So for time buying measures, or in emergencies, we can give colloids as well. Of course, like colloids are not too much available, like not that much availability is not that much common, but crystalloids are the most common one. So anyhow, this is the colloid one. Remember, it contains the large molecules, and they can expand the intravascular compartment. And then comes the crystalloids. So crystalloids, remember, they are the one which contains small molecules, right? And when they contain the small molecules, basically they flow easily across the cell membrane, um, and they are the one uh, which basically transfer from the intravascular compartment into the cells and the body tissues. So, simply, when we give someone a crystalloid, what will be the net effect? That it is not going to stay in the intravascular space, rather, it is going to distribute into different body spaces, right? So, this is the main concept you have to remember. So now there is one more concept which comes like this way. There is isotonic, they are hypotonic, and they are hypertonic. Uh, Now, what is hypotonic, hypertonic, or isotonic? Uh, in the last lecture, I was talking about osmolality and osmolarities, if you remember. So, uh, yeah, some of the surgery books, they really give a good history, and also internet is available everywhere these days, so you can go to the history. Uh, like in 1882, uh, what happened is, like, there was a guy. His name was Jacob Hamburger, and what he did, like, he run studies, and he suggested that 0.9% saline is the concentration of salt in the human body. And at that time, it was considered like it is said as it is called as normal saline. Like, and nowadays, of course, we still know what is normal saline. So uh, then there is, of course, a lot of research, and they keep on going to do research, and they keep on founding the tonicity of human blood and all these things. But um, like, with time, of course, they come to know exactly what are the fluids which are isotonic, hypotonic, or hypertonic. You can see, okay, isotonic fluids. So when the concentration of the particles means solutes, is similar to that of plasma. So simply, when the concentration is same equal to plasma, so what will happen? So of course, like, there will be no movement of solutes into the cells, and they remain within the extracellular compartment, thus increasing intravascular volume, right? So the game in emergencies is just to increase the intravascular compartment, of course, right? So you can see this one, for example. These are the examples of isotonic fluids, like 0.9% sodium chloride, which is also called as normal saline. And then there is lactated uh, Ringer solution. There is 5% dextrose in water. And then there is Ringer's lactate, or Ringer solution. And then there is Hartmann solution as well. Anyhow, we are going to discuss that thing in more detail. Uh, And now you can see over here. So I, like, this is, in the last lecture, if you remember, I show you, for example, I will tell you, I show you a diagram like this one, right? So our blood have sodium, potassium, calcium, magnesium, chloride, lactate, and bicarbonates. So see, this is the normal saline water, right? Saline, right? So thus osmolality is very much close to the blood, 308 milliosmol per liter. And it contains 154 what you can say milliequivalent per liter of sodium, and 154 milliequivalent per liter of chloride. Uh, Now this is called as normal saline solution, okay? Because the percentage of sodium chloride in the solution is similar to the concentration of sodium chloride in the intravascular space. So this is one of the solution very commonly used, available in almost all the hospitals and in the primary care centers as well. Uh, okay, so like the normal saline, when it is given, you can see to treat low extracellular fluid, as in volume deficit states, like anyone who is presenting to the hospitals by having hemorrhage or vomiting and diarrhea or having fistulas. So they give them this thing. So in this is the you can say the most commonly used resuscitation fluid as well. Okay, so in reality, basically there is no ideal resuscitation fluid. So basically it is important uh, for us to know when to administer what type of fluid. Okay, because they run a lot of studies, and they, like, in some of the studies they give normal saline, in some of the studies they give ringer lactate, and in some of the studies they do give colloids as well. So uh, what you can say, um, they didn't found any clear benefit of what makes more uh, difference, but normal saline is easily available, and uh, colloids or crystalloids, like other kind of crystalloids, they are not superior, you can say. uh, they don't have much or too much benefits. Okay, so that's why I remember, like, whenever like someone is losing blood, so the best thing you can give them is blood, because remember, like, if you are not giving them blood, whatever you are giving them colloids or you are giving them crystalloids. uh, they lack the oxygen carrying capacity. Okay, only blood have the hemoglobin which can carry the oxygen. Colloids and crystalloids, uh, they cannot carry the oxygen. So they can expand the volume, they can support, they can help in saving lives, but of course they cannot carry oxygen, right? So these are the other indications to give normal saline solution. As you can see, in mild hyponatremia, metabolic acidosis, and all those things. Then comes the Ringer lactate or heartburn solution. Okay, Ringer lactate and heartburn solution, uh, they are more or less the same solutions, right? With very, very, very little difference. You can see over here, this is the, okay, even here, like they write heartburn or Ringer lactates. So like they're considered, you can say, almost the same solutions. Basically, they have very, very, very minor differences. Okay, so now, basically, the Ringer lactate or Hartmann solution have the solutes or the electrolytes very close to what our blood really have. Okay, our blood have around 140 milli equivalent per liter of sodium. Uh, our blood have 4 milli equivalent per liter of potassium. Okay, so Ringer lactate have the same one, they contain the same one. So that's why they are the most physiologically adaptable fluid. Okay, because their electrolyte content is very much close to the what is the electrolyte content of uh, the blood or the plasma. Okay, so this makes it another choice for first line fluid resuscitation for certain patients, such as those with burn injuries, right? So this is one of the fluid. Then comes uh, okay. So I'll leave this point right now. Uh, so when this one can be used is like to replace GIT fluid losses in case of diarrhea and vomiting, uh, when someone have any fistulas, when there is burns, or someone who have acute blood loss or hypovolemia due to third space fluid shifts. So what is third place fluid shifts? I don't know if you have any idea or not. I can tell you in a very short way right now. Later on, when the topic will come, of course, we will discuss this thing in some lecture in detail. But basically, a third spacing fluid shifts is when practically you are not losing any fluid from the body, the fluid is still inside the body, but it's not in its normal physiological place. For example, the people who have pancreatitis, so what happens is that due to pancreatitis, uh, they there is something like one of the complication you can say of pancreatitis is um, pseudocyst. And now what is pseudocyst? Like the fluid started accumulating inside the tummy, okay, in a space. So that is called as third space fluid collection or shifts, because the fluid in the body started collecting in some of the space. So that is one of the example of this thing. So you can see over here both normal saline and lactated ringer may be used in many clinical situations, but patients requiring electrolyte replacement, especially like burn patients, will benefit for more from a ringer lactate. Now, a very interesting point is written over here, and you can read this one. Basically, ringer lactate have lactate. Okay, so the lactate, when it is going to metabolize in the liver, it is going to convert it into bicarbonate. Now, uh, bicarbonate is basically a base. So any patient who have acidosis going on, okay, uh, other than lactic acidosis. Why? Because ringer lactate also have lactate. So see, what is acidosis? Acidosis is when there is too much acid production in the body, number one. And due to that, the pH is decreasing, okay? So to counter that, of course, we must introduce some base in the body. So what is happening when we are going to provide any patient who have, for example, metabolic acidosis? So ringer lactate, when it is going to metabolize in the liver, what will happen? It is going to release bicarbonates. Uh, Now the bicarbonates are the one which is going to uh, try to balance the thing, right? What one exception is, remember, lactic acidosis. Why? If you know lactic acidosis, there is accumulation of acids with lactic, okay, lactate. So of course, in that case, if you are going to provide with this thing, you are going to provide them with more lactate, so the condition can become bad. So remember, like as ringer lactate or lactate is metabolized in the liver, so one of the thing is lactate is metabolized in the liver. So never give this type of fluids in the liver. Uh, Patients whose like liver is not functioning well, or someone who is in hepatic failure, of course, they cannot metabolize lactate. Okay, so that's the important point. So after that, again, like this is the more explanation of that. Okay, then comes the dextrose, or okay, how they uh, write dextrose in the hospitals. They write D5W, or dextrose 5% of water. So basically, this is the solution which have just dextrose, or you can say sugars, right? Uh, Now, basically, this is considered as isotonic, but in reality, this solution is not isotonic. Why? Because when we give this solution to any patient, what will happen? That the glucose is going to metabolize by the body, and of course, when the glucose is taken away from the solution, um, of course the osmolality of the solution will be decreased. So once the osmolality of the solution will be decreased, what will happen? that this solution is going to become a hypotonic solution, right? And of course, like when the blood is going to become hypotonic, what will happen? That blood is going, or like the water or the fluid is going to shift inside the cell. And why the fluid is going to shift inside the cell? Again, if you know uh, what you can say, the basics of osmosis, so you would understand, right? Because in osmosis, what happens, that the fluid basically is transported or moves along a semi-permeable membrane from an area of lower concentration towards the area of uh, higher concentration. So of course, uh, when you give someone with dextrose 5 water and the glucose is metabolized, uh, the solution, or the pH will become, sorry, the tonicity will become isotonic. So what will happen? That the fluid will start shifting inside the cell uh, to maintain the hemostasis, right? So this is dextrose 5 water. So now this is the main, this is more explanation of that. And I remember this thing that dextrose will give energy to the body, okay? But remember this thing, that dextrose 5 water doesn't contain any electrolytes, like um, sodium chloride solution, like the normal saline solution, Hartmann solution, or Ringer lactated solution, all contain electrolytes. And this is a fluid which is not going to provide with electrolytes. Okay, so like we can give this solution to anyone uh, who need some calories as well, who need some energy as well. Of course, like you would know when you will start working, especially in surgical wards, whenever we put any patient on uh, a fluid replacement, what we do is basically we give them, for example, if we have to give them 3 liters of fluid in 24 hours, so a very good idea is to give 2 normal saline with 1 dextrose water. So of course, uh, 2 normal salines will give them, provide them with sodium chloride or sodium especially, and one, this one will give them energy as well, and we can add potassium as a separate injection, right? So this is how in reality they give the fluids. So remember, this one is not good for the patients with renal failure or cardiac problems, since it can cause fluid overload, and patients at risk for intracranial pressure should not receive dextrose 5 water, since could increase cerebral edema, especially someone who have already swelling of the brain, and you're providing them with dextrose 5 water. What will happen? It will cause the fluid to shift inside the cells, right? And when it is good, like the fluid is going to move inside the cells, so what will happen? The cells will swell up, and when the cells will swell up, so it can worsen the cerebral edema. So this thing, so that's why we use it with like mixture, okay, a normal saline with this one. So this thing, and uh, this is the difference between normal saline and dextrose 5 water in distribution, like how much free water content this one have or this one have, how much of this one will be distributed in the ICF, in the interstitial fluid, and in the intravascular space, right? So after that, um, like, okay, these things, by the way, these points which are written, maybe you will understand now, but once you will be having the concept about all the body compartments, of course you would understand what's going on, right? So next one is okay, Okay, whenever we give and at the IV fluids to any patient, as I was talking about like in the previous lecture, basically what we do, we keep on checking the vitals, we keep on checking the lungs, especially because whenever you are going to fluid overload any patient, what will happen? They can develop pulmonary edema, for example, right? So uh, anything can happen, like that's why, yeah, like we must be careful, right? Especially in heart patients, what we do is like we are very cautious when we are giving them IV fluids, because we don't want to uh, overhydrate them. Of course, it can lead to what you can say heart failure, okay, or it can lead to pulmonary edema as well. Okay, hypotonic fluids. So of course, like hypotonic fluids should have the tonicity less than that of the blood, the plasma, and of course there are different usages of hypertonic fluids. There are different usages of hypotonic fluid. The hypotonic fluids, like as we know, the osmolality of the blood, the plasma. I told you how to calculate that in the previous lecture. So uh, of course, like their tonicity is less than that of the plasma, so uh, around 250 or less than that. Hypotonic fluids, of course, like crystalloid solutions, when we will give, of course they are going to decrease the serum osmolality, okay. And when the osmolality of the serum will be decreased, what will happen? uh, the fluid is going to shift uh, into the intracellular spaces, right? The fluid is going to go inside the cells. So remember, like guys, whenever we are going to give anyone with hypotonic fluids, what will happen? Basically, the fluid will move inside the cells. So basically, it is going to hydrate the cells. Okay, these solutions will hydrate cells. Okay, but they are not of so much benefit, of course, like in expanding the intravascular spaces. So uh, these are some of the examples of hypotonic fluids, and see, it's not a big science. We know that 0.9% normal saline is the isotonic fluid. So if we will make the concentration of normal saline, or like the sodium chloride in that solution, to half, so it will become half normal saline. So for example, 0.45% sodium chloride, okay. So this is half normal saline means what? uh, See, in that one, they have mixed, in 1 liter of water, they have mixed 154 milliequivalent of sodium chloride and 154 milliequivalent of like 154 milliequivalent of sodium and 154 milliequivalent of chloride. But if you are going to mix uh, one, like what is the half of 154? It will be like 77 milliequivalent of sodium and 77 milliequivalent of chloride. So that will become half sodium chloride. Uh, this is 1/3 sodium chloride, then there is 0.2% sodium chloride, or for example, 5% dextrose, have the tonicity same like plasma. So if we will decrease the concentration of glucose in that solution to half, like which will become 2.5% dextrose, so it will become hypotonic fluids. So now hypotonic fluids, as I told you, they will hydrate the cells. So these are the fluids which basically are used for intracellular dehydration, okay, such as in hypernatremia, such as in diabetic ketoacidosis, or such as in hyperosmolar hyperglycemic states. So I think in physiology you guys must know this concept, very basic concept, and uh, we are learning this thing, from a long period of time. So I don't think so it would be difficult for you to understand. Okay, what's going on over here? So remember, like whenever we give hypotonic fluids to any patient, they are very poor volume expanders. They are very poor because they don't stay for a long time in intravascular space. So remember, they should not be used in the treatment of shock. Okay, uh, or especially like in shock patients, if you will give them, so what will happen? That they are not going to help that patient. So they can cause hypovolemia or hypotension. So I remember this thing, right? After hypotonic fluids, like the next one is hypertonic solutions, and of course their tonicity is more than that of plasma. So when their tonicity is more than that of plasma, if you know the tonicity of or the osmolality of the plasma, you can understand, like you can remember, like they will be more than that. For example, here, like their osmolality is like around 375 milliosmol per liter. And again, the same thing, guys. Uh, um, if we are going to give someone with the hypertonic solution, so now the tonicity is less inside the cells, uh, more in the plasma. So they are going to drag the water from the cells outside. So the cells will be shrink. Okay, the cells will shrink. So why? Because like because of this hypotonic solutions, the water will come out of the intracellular spaces, increasing extracellular fluid volume. So they are used as volume expanders. Okay. So now some of the examples, again the story is same. Normal saline is 0.9% normal saline. Anything more than that will become hypertonic saline. For example, 3% sodium chloride. So anyone who have severe hyponatremia, their sodium is very less. So of course we have to fix the sodium. So of course this solution will be having a lot of sodium. We can give this one. A patient with cerebral edema, when we give them hypertonic solutions, it is going to take the water outside from the cell. So one of the things is this one. Okay. Or for example, if you will mix 5% dextrose in normal saline, of course, like it is going to make it hypertonic solution, right? What are the precautions with hypertonic solutions? Uh, like of course they are not used for resuscitation, or even the hypotonic one are not used for resuscitation, but hypotonic solutions can cause intravascular fluid overload, so they can lead to, as I told you, we keep on checking the lungs especially because we fear, like there is a fear of pulmonary edema. And uh, of course there are just few indications for by like in which we give hypotonic solutions. Okay, guys, then comes the colloid solutions. Now, as I told you, that colloids are the those which have very large particles or solutes, you can say, right? So, what they do, like when we give anyone with colloids, what will happen, that they are going to drag the fluid into the intravascular space, right? So they have the same effect as hypertonic crystalloids, simply, right? Uh, so the thing is, there are a lot of colloids which are available nowadays, right? Uh, for example, one is 5% albumin solution. You know what is albumin? Albumin is a protein, and remember, proteins are those. Our protein have oncotic pressure. They attract water. They can keep the water in that compartment, and that's one of the reason when someone is in hepatic failure and the liver is not producing enough proteins like albumin, what can happen is simply uh, due to that the fluid cannot stay inside the compartment, and the patients, they started having edema. And that's the reason that the patients who have renal failure, they also have edema. So 5% albumin or human albumin solution, most commonly utilized colloid solution. It contains plasma protein fractions obtained from human plasma. It is used for volume expansion. it can also replace proteins. Okay, so these are the things. But of course, like all the colloid solutions are expensive. So certain conditions in which we cannot give albumin, of course, we must keep that thing in mind. Okay. Uh, okay. This one is, of course, like about the transfusion reactions. We are not discussing now. Okay. Other colloid solutions. There is hydroxyethyl starches, right? Uh, so this is again a hypotonic synthetic colloid. Of course, albumin is the one which can be manufactured or which is manufactured or which is taken from the human plasma, uh, whereas this one is a synthetic one. It is less expensive and the effect of the solution is more than that of albumin. And okay, other than that, um, okay. So anyhow, we have discussed this thing, what is maintenance therapy, okay, and what kind of things we can use. If you want to read it, like maintenance therapy is the one who is not taking anything by mouth. So of course, like I told you in the previous lecture, what is the daily requirement. So of course, we must give them to the patient. Plus, what are the ongoing losses? If they have any NG tube, any drains, whatever, we must provide them with that thing. Okay. Okay, so this thing, and you can see, for example, from here, uh, like the same thing, 5% dextrose water, it's isotonic with extracellular fluid, and it is therefore the solution to use if you think a patient is dehydrated, that is deficient in water alone, for example, by fever or absence of normal intake and needs water. Of course, it is going to give them energy and they have the electrolytes already in their body, so they don't need any electrolyte, right? So see, like the same point which I was explaining, dextrose intravenously over a short period, say an hour, is a useful maneuver if you think dehydration is the cause of patient's lower urine output. Of course, like if you think the person have a pure water loss, okay. Again, one thing, normal isotonic saline, which is isotonic, of course. I talk about these things, and then there is 4%. Okay, yes. Sorry, this one I must delete this thing so that you can see it clear. You can see this one. One of the example of the isotonic fluid is also 4% dextrose in 1/5 normal saline. So what they did, like they put 1/5 concentration of sodium chloride, and see they decrease 1% of dextrose. So uh, that makes the osmolarity near to plasma. And this one will be having sodium, this one will be having chloride, and this one will also give energy to the patient in the form of dextrose. Okay, so Ringer lactate and Hartmann solution, as I told you, use lactate to increase the tonicity, and more closely they are close to the extracellular fluid. They contain sodium chloride, potassium, lactate, calcium, all these things. Okay, so they are regarded as sophisticated extracellular fluid replacement. Again, the same point, lactate is metabolized in the liver with the release of bicarbonates. So acidotic solution makes it a good sense, but of course we must avoid that this thing in alkalotic patients. One more thing, we must avoid this solutions in liver failure patients. Uh, wait. Oh, okay. So I don't know how to make it disappear. I think by this way, yes. So potassium containing fluids, as we know that the potassium is present too much inside the cells, and as I was talking before, whenever we give anyone a fluid, so we also replace potassium. So the thing is, uh, Remember, like whenever there is any abnormality with the sodium, the patient may have neurological symptoms. Why? Because they can have brain edema. But whenever there is some abnormalities with the potassium, remember it can lead to heart troubles like arrhythmias, right? So we must be very cautious when we are replacing anyone potassium. So this is about the fluids, which I talked before as well, which I'm talking today as well. Guys, now, as I told you that uh, it's not only important to remember or to read about the fluids, but it's very important to talk also to read about what is hyponatremia, what is hypernatremia, what are the causes. Okay, same thing. What is hypokalemia and what is hyperkalemia? Okay, and the acid-base problems as well. Okay, like metabolic acidosis, alkalosis, and all this stuff. Why? Because remember that you would never understand the fluid replacement science without, if you don't know what is the role of sodium, what is the role of potassium, and what you can say acid base imbalances, right? And the good thing, like we already covered this thing, like in medical schools they teach us in physiology. I think like physiology is a very nice book to cover these things, like if you don't know. Okay, so anyhow, like this is again a table which are showing you crystalloid solutions. This is the normal plasma. What are the sodium, chloride, potassium, calcium, glucose, bicarbonate, osmolality, tonicity, and typical indication. So they are talking about normal saline here. The indication is of course resuscitation. I told you this is one of the best resuscitation fluid. Then there is half normal saline. Uh, C 7777. It is hypotonic, used for maintenance. Then there is 3% saline, which is a hypertonic solution. See, they increase it the value threefolds. It's hypertonic. It is used in severe hyponatremia. Then there is uh, half normal saline with 5% dextrose. Of course, like this is an example of hypertonic, right? Because if it will be 4% dextrose, then of course it will be isotonic. But uh, if this one will be 4% dextrose with 1/5 of normal saline, but this one is of course hypertonic, right? So now the good thing about this one is what it is hypertonic, but dextrose uh, once it will be utilized, so it will become hypotonic, right? Because half normal saline is what will left. So simply, if we will give this solution to any patient, after some time, when the glucose is utilized, this fluid will become this fluid. Okay, so it is also used for maintenance. Then there is dextrose 5 water, which is hypotonic. Why hypotonic? I told you that, but basically it is isotonic. But once you will give them and the glucose is utilized by the body, what is left is pure water. So it will become hypotonic, right? Then there is lactated Ringer's lactate or Hartmann solution, which is isotonic, and it is also a good fluid for resuscitation. Okay, I hope you understand, because like the concept is very easy, and if you know like the basics, it's very easy to understand. These are some colloid solutions. This is the same slide which I uploaded last week, and you can see 5% albumin. There is 20 to 25% albumin as well. There is 10% dextran also available, and then there is 6% hydroxyethyl starch hespan. This is the trade name, and you can see like the average molecular weight, the oncotic pressure they exert, and how much volume expansion they can do, and how much time they can stay inside that compartment, or how much time they work for. Okay, you can see over here 6% hydroxyethyl starch works for longer time. 10% dextran works for a shorter time. Why? Again, the concept is same, guys. When this one will be utilized, of course it will be gone, right? Whereas the albumin works for around half day to 1 day, 12 to 24 hours, right? So this is about the colloid fluids. I put this slide in the end. Why? Uh, as I told you, that this lecture and the next lecture will be about shock, and in shock, of course, we do resuscitation, and when we do resuscitation, of course, we give fluids. So that's why we are studying them. So what is this? Uh, MAP is mean arterial pressure. CVP is central venous pressure. Okay, so all these things, of course. We keep on checking in any patient who need resuscitation. So once we are resuscitating any patient, what happens is, uh, we keep on checking these, and if anyone whose mean arterial pressure is more than 65, central venous pressure is more than 8 to 10 millimeter of mercury, urine output is more than 0.5 milliliter per kilogram per hour, so and their lactate is normal and they have their mental status is normal, it means they are adequately resuscitated. Okay, so you can say like these are the global indicators or parameters which will tell you that the patient is enough, like resuscitation is enough. Okay, like the mental status is fine, so of course the brain is getting the required nutrition or oxygen, right? Urine output is more than 0.5 milliliter per kilogram per hour. It means what? The kidneys are getting enough perfusion and they are working fine. Mean arterial pressure is more than 65 millimeter of mercury, means what? That there is enough blood inside the intravascular space. So all these things. So guys, this is not uh, enough. Remember, I told you that it's not enough to just read this thing. Rather, it's important to uh, read about acid-base balance, hyponatremia, hypokalemia, hyperkalemia. In acid-base balance, remember there is metabolic acidosis, there is respiratory acidosis, there is metabolic alkalosis, there is respiratory alkalosis, there is mixed acid-base abnormalities as well. So um, uh, all that things, of course, like without them, like you cannot make good concepts, right? You can see over here maintenance therapy, how to calculate. There is 4 to 1 rule. Basically, this thing, when I teach pediatrics, so I give a very good detail about this way. Like any pediatrics, like because this rule is mostly used in pediatric patients. For the first 10 kgs, we give them 4 milliliter per kilogram per hour. Next to that, next 10 kgs we add 2 per kg, and next to that we add 1 milliliter per kg per hour. For example, if you want to calculate for someone who is 25 kilograms, so for the first 10 kilograms they need uh, 40 milliliter per hour. Okay, for the first 10 kgs, then for the next 10 kgs, so this is how we calculate. So this thing, and we have discussed these points in the previous lecture. Okay, all these points we have discussed in the previous lecture. Okay, like what are the signs of fluid overload and what are the signs of fluid or hypovolemia, right? Okay, so how we can give fluids? We can give by IV cannulas, peripheral IV lines, centrally placed catheters, peripheral midline catheters. These are the catheters which we put from peripheries, but they come in the center. Okay, and then there is Hickman's lines. Okay, as well. So this one, and then there is a lot of other signs. I don't think so like we are going to talk about them in this lecture, not like how to calculate IV flow rates and all this one, of course, like they are like you can say some other things which we'll discuss if we had some time someday, right? So that's all, guys. Again, I'm saying again and again and again, try to read acid balance imbalances, try to read hypokalemia, hyperkalemia, hyponatremia, and hypernatremia, right? Uh, very, very, very important to study all these things. Um, that's all for now, okay? And all the slides which you are seeing, okay, they are available online, they are available in the books, okay? So uh, better to better to read it from some basics books like basic sciences like physiology books, okay, because they will start from very you can say from the scratch, you can say, and they will help you in making good concepts, right? So like try to read all these things, okay? So thank you so much for listening, and I will see you next week.